I'm going to bring him back.
Yeah, do it.
Yeah. Breakout rooms. All right.
Who's Aka?
I don't know.
Hey,
I'm
sorry, it's
scared.
Akanksha.
Oh, okay.
Sorry.
Sorry about that.
I was using my phone because I was walking to work.
All right. I think everyone's back. Oh, why don't we hear from group one for why this is breakout group one for why this is endocarditis?
All right. Hi, guys. So we chose endocarditis with septic emboli. And so this is a guy, he's been having about a week or two of fevers, headache, myalgias, which, you know, could be in the setting of bacteremia or some sort of endocarditis picture. He's a lot of outdoor exposure, maybe got a tick bite and got some sort of infectious disease. Or maybe he uses IV drugs. He had a fever, and then all of a sudden he had this, what looks like clogged brain vessel, which I cannot identify based on its location on this imaging. And maybe he threw a clot from his endocarditis.
All righty.
That's the end from me.
That was good. Thank you,
Thank
Jillian.
you for your time.
Let's hear from group two who had of why this is Lyme disease.
I'll take a stab at it. So we got a guy who goes camping in the Northeast, presenting with basically kind of like subacute fevers, headache, and myalgias, and then ending up having rash and lymphadenopathy. So we kind of went with Lyme disease, possibly like an early disseminated Lyme kind of picture, which can end up giving you some neurological symptoms late if it's left untreated. That's pretty much kind of like where we went with that one.
Sounds good. Thank you, Keel. Let's have group three who did cysticercosis.
So we were trying to link the LFTs in the brain lesion. And we figured a space-occupying lesion could cause this focal neurologic deficit. So we said he had neuroinvolvement of cysticercosis, which can cause headache, focal lesions, or focal deficits. His myalgias could be explained by skeletal muscle involvement. And then if he had a liver cyst, that could explain his LFTs as well. You can also have skin involvement, although that's more like subcutaneous nodules, it seems like, and not so much this rash, but.
Perfect. And then lastly, group four, why do you think this is syphilis?
All right, so we have a 40-year-old gentleman with multiple risk factors for syphilis. He's sexually active with multiple partners. He's not using condoms. He actually had maybe had a chancre in the past that he forgot to mention on this visit. Now he's coming in with tertiary syphilis with neuro involvement and concerning for neurosyphilis. He's coming in with a stroke, and actually Kirpal told me that commonly these strokes will present with ototic involvement and hearing loss, which is what he's presenting with. And then as we know, syphilis is a great mimicker. He's coming in with a rash. The rash actually extends throughout his entire body, but also onto his palms and soles. Lymphadenopathy, some liver involvement, maybe from gummas from tertiary syphilis. We're thinking we should probably get him some penicillin as soon as we can.
Sounds good. All right. And now for all the points, the judges who are Navi and Dr. Wickersham, who was the most convincing to you? I don't know if they want to talk to each other or how they want to do this.
Maybe I'll message Navi in the chat box.
Okay.
All right. All right, I think Navi and I are on the same page.
Okay. Who do you think won?
You know, I think group 4 was really convincing on why this could be syphilis.
All right, perfect. So group 4, you win, and I'm gonna do some teaching now. And you know, I just going over these cases, I made this case, so it could be different things, and I think it could be a lot of the things that you guys really talked about. There's, you know, different terms. One is diagnostic adequacy. So when you think about a case, diagnostic adequacy means that every single thing within that case, sorry, my pointer's not working. Every single thing in that case is explained by a specific disease. So when we kind of go through the diseases that we have here, what kind of diseases could be explained, could explain every single symptom in this case? So I think one of the two biggest diagnoses were when I thought of this was Lyme and syphilis. But, you know, thinking about syphilis, how does, you know, syphilis work? So basically you have, sorry, I'm going and having some issues real quick. Let's see this, per usual. 1 second. So kind of how does syphilis work? So the spirochete is kind of injected into the skin, and then it moves subcutaneously, basically to the periphery, and then actually comes back up near close to the skin again, causing this inflammatory reaction, which creates your very typical bullseye rash. With really any spirochete, the problem is that what gets to the skin, where that rash is eventually controlled, but then it gets disseminated. So for stage 2 Lyme, a lot of the things in this case were pretty similar, right? You have the spirochete that disseminates, so that can go to the CNS. It can cause meningitis. It can cause a cranial nerve 7 palsy as well, which you can see here. Not present in our case. It can go to the heart, causing heart block. You know, in rare cases, it can cause myocarditis as well. And this is an MRI basically with gadolinium enhancement with myocarditis. It can go to, even with with early disseminated Lyme, it can go to the joints, causing inflammatory arthritis, which would always be a differential for monoarthritis. And you can actually even have dissemination into the skin, causing multiple erythema migrans, and sometimes it can actually even look like erythema multiforme. So it can even look like a lot of erythema migrans, or sometimes even like erythema multiforme like lesions. So we had a rash, we had some neuro involvement in this case. The way that Lyme spreads is kind of interesting. It actually doesn't have any pathologic mechanisms itself. It actually kind of binds itself in factor H and plasminogen, which is just normal stuff that's present in all of our bodies, but it binds itself to these things so that it can hide from the immune system. So a lot of the reasons why Lyme actually causes disease and causes manifestations of inflammation, and especially the reason why it causes the long-term manifestations is, first, it can become sequestered in long-term sites like the CNS, the joints, and the skin. But actually, because it does molecular mimicry and it actually coats itself in molecules that are present in the normal human body, the body actually gets confused and it starts actually attacking itself, and it starts attacking your own cells, and it creates its own inflammatory reaction. in which a lot of people will get chronic Lyme disease because even when you kill that Lyme off with antibiotics, the body still is attacking itself because it's been so confused by this spirochete that it's coated itself in its own molecules, that it's its own self antigens, that you actually create a autoimmune system kind of against your joints. And sometimes these patients can also have long-term like headaches, and they can even have like cognitive function as well with chronic Lyme disease, or basically it's an autoimmune reaction in which breakdown of self-tolerance due to the molecular mimicry of Lyme. So we definitely had some stuff in this case, right? We had the typical meningitis, and long-term Lyme can actually get encephalomyelitis as well, but this is usually after about 6 months. Things that weren't present here, our patient did not have a cranial nerve 7 palsy, which is very common. The patient did not have any heart symptoms, which is pretty common. Our patient didn't really have much arthritis as well. And the other things that our patient did have was that kind of diffuse lymphadenopathy and a diffuse rash, though I didn't go that much into the rash. So the next thing to think about is syphilis. And I like to teach these together because they're, from a pathophysiological standpoint, they're very, very similar. So syphilis, we all know is an STI, and it starts off with its chancre, right? The chancre can be on the genitals, but it can also be on the tongue. It can also be in the anus as well. So if someone comes in with a lesion in one of these spots, have syphilis on your differential, just like Lyme again, it goes from that chancre and it goes into the bloodstream. And really this dissemination is limited by T cells. So patients who have T cell dysfunction will have a higher risk of having disseminated Lyme disease. Dissemination of syphilis. So once again, it goes into your vasculature, and then it goes to a bunch of different sites. And a lot of the sites that were really present on this case. So for secondary syphilis, it goes to your skin. And one of the major rashes that we get is this diffuse rash all over the body. A lot of times it's almost copper looking, what has been described, and sometimes it may even have some scale on it. That's the most common, a maculopapular rash with some scale. But you can have a nodular, you can have a pustular rash, you can have an ulcerative rash. It can be kind of anything. But most commonly maculopapular with a little bit of scale. You can get dissemination to the reticular endothelial system. Here's some with lymphadenopathy and hepatitis. So this is a patient with epitrochlear lymphadenopathy, which can be common in syphilis, or it's not common, but it's more specific for syphilis. And then for HENT, you can also have it, go to your mucous membranes with condylarthria lata. You can also have alopecia secondary to syphilis too. In this case, this patient had secondary syphilis at the same time of having neurosyphilis, which really is not uncommon. There's dissemination through the entire body when these patients, get syphilis. And a lot of times neurosyphilis may come out a little bit after secondary syphilis, but a lot of times they kind of occur at the same time. And what kind of things do you get with neurosyphilis? So you can get otic involvement, so otosyphilis, eye, which wasn't present in this case, but here's a patient. Usually it's going to be uveitis is the most commonly, but it can affect any part of the eye. Here's meningitis. And then the reason why we care so much about syphilis, or one of the reasons why we care so much about syphilis, is for meningovascular syphilis. This causes irreversible damage and infarcts to the brain. And it typically presents actually a lot like this case, where the patient will have meningitis for about 1 to 2 weeks. And then they may have like an acute onset stroke. And in this part of the case, this patient had an MCA stroke right here, and also had some basilar stenosis, but I gave you the symptoms of really an MCA stroke. And you can see the infarct here. It sounds like it's mostly due to invasion of your meningitis, and then from your meninges, and then invasions into your micro and macular vascular in your brain, causing an inflammatory reaction of vasculitis, which then causes, thrombosis and stenosis. So that's really the reason why we care so much about syphilis is the meningivascular involvement, and that these patients can, if untreated, can have a stroke from it. Chronically, secondary syphilis after years to decades can go to tertiary syphilis. Here's a patient with a gamma. And then we also have cardiovascular syphilis, in which you have aortic dilation and even osteostenosis of your coronary arteries. So here's some stenosis basically right at the ostium of the coronaries. And for late neurosyphilis, this doesn't usually happen anymore. Tabes dorsalis, which is involvement of the posterior columns and the dorsal roots. And then also one thing that we don't see much anymore is general paresis, which is a dementia-like state that can be caused from syphilis, mostly described by change in personality. Change in personality, forgetfulness, some patients can even have psychosis. So, like the diagnosis could be anything, and we do this really to teach you how to go through a diagnosis and go through a differential. But in this case, I did have syphilis in mind, and really in this case too, I didn't give you this, I didn't give you hints of it, but I was thinking about a patient that had HIV and then eventually getting syphilis, because when patients have HIV, especially if their CD4 is less than 350, they're much, much more likely to actually rapidly progress to early neurosyphilis. And sometimes patients with HIV, early neurosyphilis can really be their initial presentation. And they're more likely to have like otic involvement, eye involvement, and they're more likely to progress with meningivascular syphilis, especially if their CD4 count's less than 350, which, we always think about a CD4 count less than 200 as, getting opportunistic infections. But for syphilis, which really isn't an opportunistic infection, less than 350, they can have a really high risk of getting things like neurosyphilis and having a pretty bad secondary syphilis as well. All right. So that's kind of most of what I had for this case. I mean, I think it's just an interesting case for syphilis, but I think now let's just kind of go through maybe like the workup for syphilis, because I know, especially outpatient, we have a lot of issues with this sometimes. It's just difficult, actually, really. So you're at JHAP, and a 28-year-old male comes in for a general exam for screening. He screens as high risk for sexual behavior, has multiple female partners about condom use. So you send for syphilis as well as a full STI workup. He said he's never had syphilis before. The FDA ABS comes back positive, but the RPR comes back negative. What would be your next step for this patient? So you guys can put in the chat or, talk out loud. It's a pretty hard question for sure. But it's one that you do get, I think I got a similar question like this from MixApp. All right, got some coming in. I think some people were still in private, so I got some privately as well. But I got a good smishmattering of kind of different answers, and I think this is a hard question, and if you've never looked at this before, you really wouldn't know. So let's just kind of go through this answer. So how do we work up asymptomatic syphilis? You always send off the syphilis cascade, which is you start off with we used to do an RPR, then an FDA ABS, but now we actually do an FDA ABS first, and then we reflect it to an RPR. So the FDA ABS, like, what is it? So you actually take the antigen and you have it in basically a test tube, the antigen of Treponema pallidum. You take the patient specimen, And your thought is that the patient specimen will have an antibody to the treponema pallidum, which is in the test tube. You combine them together and they link. Once they link together, then add some conjugate, which will fluoresce if it attaches. And the signs of that fluorescence means that the patient has an antibody in their serum that is directed against treponema pallidum. If that's positive, it's pretty good. It's 85% sensitive, basically 100% specific. So the thing it doesn't tell you though for the FDA ABS is recency of infection. This is going to be lifetime. So it's an antibody. Once you've had treponema pallidum and your body has created that antibody to syphilis, you're going to have the antibody for the lifetime. So it's really never going to become negative. A little bit different for RPR. So what RPR is, it's a reagent, and they have basically this reagent in a well. And this reagent, it's kind of weird. It's made of like cholesterol and lecithin, I think. But it's similar to the molecular makeup on the outside of syphilis, and it's similar to the antigens that are present on syphilis. So they take that reagent, they put it in the pool, and then they add the patient's serum. And the patient should have a bunch of IgG and IgM that will attach to this, that basically will attach this reagent. And then how much of it attaches actually shows you how reactive the patient's serum is for syphilis. And it actually will give you weakly reactive or strongly reactive, and that'll give you a titer. So the thing that's interesting about this is that first it quantifies with a titer how reactive their body is against syphilis, and it actually will be higher if recent and will wane over a long period of time. So if someone had syphilis a long time ago, then their RPR may actually be negative. So it does have some recency to it, which is nice as well. So like I said, we start off with the FDA ABS. If they have a positive FDA ABS and a positive RPR, I mean, you're pretty much good. Syphilis diagnosed. That means they've had it before and they've probably had it pretty recently. So syphilis is diagnosed. In some cases, this may be not helpful if they had a very recent diagnosis of syphilis and they were treated, their RPR will stay positive for a while. So that can be one time where this might not be super helpful, but almost for any cases of someone that does not have a recent history of syphilis, if you have a positive FDA and ABS and a positive RPR, you're good to go. The problem is when you have a problem, FDA ABS or one of the treponemal tests, and then you have a negative RPR. So where do you go from there? So one of the things that I gave you is that the patient had a history did not have a history of treated syphilis. But if the patient has a history of treated syphilis, then this is what you would expect. That RPR should decrease over time and become negative. And the FDA ABS is going to stay positive for the entire life. So if they have a positive FDA ABS and a negative RPR, you're good. That's consistent with history of treated syphilis. If they've been treated before, you don't have to do anything else. What do you do then if they have a positive FDA ABS and negative RPR and no history of syphilis? So at that point, you actually have to do another treponemal test. And usually it'll go with like TPPA or TPEIA, which is an ELISA. And if that is negative, it's negative for syphilis, and that's positive, it's positive for syphilis. All right. So in this case, you would check another treponemal test. It's kind of an obscure question, but I did get some syphilis on my boards, and I also got, this was kind of from MixApp as well. All right, and then lastly, same patient, but you check the second treponemal test and it comes back as positive. You decide to treat them. He says, I've never had syphilis before, can't ever remember having an ulcer, but he doesn't check that often. What is the correct treatment? Do you want to do penicillin 1 dose IM? you want to do it penicillin, 3 doses in 1 week intervals? Do you want to do IV penicillin or you want to do doxy? All right, we're running out of time, and I got the correct answer privately. So treatment of syphilis, this is always kind of difficult. So I kind of divide these into primary, secondary, and early latent, which I put in one category, which will be, either you have that primary chancre, or you're going to have, signs and symptoms of secondary syphilis, but not neurosyphilis, just secondary syphilis. Or you're going to have early latent, and early latent is described as having that chancre less than 1 year ago. So you've had syphilis in your body for less than 1 year. And then the other category is late latent, which is greater than 1 year or an unknown amount of time for syphilis or tertiary syphilis. And these have different treatments. So if you have primary, secondary, or early latent, you do just 1 dose of penicillin. And if you have late latent, which is having syphilis for greater than 1 year, or you have tertiary syphilis, you do IM penicillin weekly for 3 doses. So in this case, we don't know. Like he said, he's never had a chancre before. We really have no idea. So we kind of have to put this patient into the late latent category, and we give him penicillin G weekly for 3 doses. I'm running out of time because I usually stop at 35. But our first patient, we said had neurosyphilis. What do you guys think would be the correct treatment for neurosyphilis? And you may have seen this in the hospital a couple times. Any ideas? Perfect. Yeah, so the correct treatment for neurosyphilis is going to be IV. And it's going to be IV penicillin G for about 10 to 14 days. If someone has a mild penicillin allergy, you can do ceftriaxone, but I think you should really be trying at all times to do penicillin, especially if it's a patient who is pregnant as well. Does anyone know, and this is kind of cool, just connecting this back to Lyme, which I feel like has the same similar pathophys as syphilis. Does anyone know how the second line treatment for these 2 types? So say if they're not pregnant, but they're severely allergic to penicillin. Yeah, exactly. So I got in the chat, doxy, and I which I think makes sense. I mean, I think, they're both spirochetes, syphilis, and Lyme. So they have similar treatment regimens. So if you can't use penicillin, you should try your best to obviously use penicillin. And like if it's a pregnant woman, you actually have to desensitize them to penicillin. But if you can't use it, doxy would be your next line. All right, and that's all I got. I hope you guys enjoyed it. Great job getting the case. I know I made it super obscure, the case pretty obscure and difficult, but I think you guys did awesome. So thank you. Any questions about anything? All right.
Thanks, Nick. A great case.
Yeah, it's a great case, and it was totally fair. Totally fair.
All right, thanks, Nav.
Thanks, Nick.